This-
Hi, I'm Dr. Keshishian, and welcome to our podcast series, PPE, Podcast for Psychoeducation During the COVID-19 Pandemic. Last week, we spoke to Dr. Steven Siegel, Chair of the Department of Psychiatry at USC, and we spoke about the resources that were available there. Today, we're going to take a deep dive into the Department of Mental Health and the resources available to the community through DMH. I'm joined by Dr. Curley Bonds, the Chief Medical Officer at Los Angeles County Department of Mental Health. Hi, and thank you for joining us.
Thank you so much for having me. Glad to be here.
Dr. Bonds, could you tell us a little bit about yourself?
Sure. Well, I am a psychiatrist, and as you mentioned, I work as the Chief Medical Officer for the Department of Mental Health for LA County. And we happen to be the largest public mental health system in the country. And so our jobs are really, really intense. In fact, I would say that of our 6,000 employees, about 250 are psychiatrists. So as the CMO, which is the acronym, I oversee all of psychiatry as sort of the de facto chief of the psychiatry service. And I also oversee the majority of clinical operations. There are 4 members of our executive team. I'm one of a great team of 4. Dr. Sharon is the director, who's also a psychiatrist, Mr. Greg Polk, our administrative chief deputy, Lisa Wong, who's our senior deputy. We oversee the whole range of treatment from outpatient to intensive services, community-based treatment, our forensic services. So there's a lot going on here.
Wow, thank you. Can you tell us a little bit about what prompted you to become a psychiatrist and then kind of your journey on how you became the CMO of such a large organization?
It's an interesting question. I'll give you the Reader's Digest version. Well, I am the son of a biology teacher. And I always start with that because my mother, who was a high school biology teacher, always emphasized life sciences. And so it kind of was in the background all growing up. You know, if I asked a question about why are plants green, she could actually give me an informed answer. And so it was always something that came easy to me and it was natural. So when I went on to college, at first I thought, well, maybe I'll be a biology major, but I ended up majoring in sociology. And that was because I was pre-med, which was an intense curriculum. And I had some inkling that I might go into medical school and I wanted to be really well-rounded. So I did a bunch of stuff, but I ended up living in a place at Emory University that was very embedded in healthcare. It is a large pre-professional school for all the different health professions that influenced me a lot, just being on campus and seeing folks in their white coats going to the hospital. I kind of thought, you know, I'm good at biology, I like people, and so medicine became the draw. And then when I went on to medical school at Indiana University, I took all the rotations, but the thing that I had the most penchant for and seemed to come easiest for me was psychiatry. And I joke now sometimes that it's because my whole family has mental health issues, and I, did have one close family member who had a serious mental illness, and that influenced me deeply. Seeing her recover, seeing her get better, it helped me understand that psychiatry was a legitimate part of medicine. So I was never one of those folks who disparaged it or who felt like psychiatrists aren't real doctors. So I ended up going to a psychiatry residency at UCLA. And then at the Semel Institute, now it's called, I really loved teaching. And it was really a big part of what I did. In fact, I graduated from the program there and spent a good 10 years working as the director of consultation liaison psychiatry, which is sort of medical psychiatry. So it was really at the interface of people that are in the medical hospital who need psychiatric help. I actually worked with heart transplant patients quite a lot, which is where I met Dr. Sharon, honestly. He was a trainee through the residency program there. So we were in touch, but didn't really keep in touch. I went on to do a number of other things. I left UCLA and I went to Charles Drew University in South LA as the chair of psychiatry and also the program director for the residency training program. And that job closed when the hospital did. I went briefly to the jail, not because I committed a crime, but because there was a need. They had a lot of trainees rotating through the jail, so I became the director of quality academics and research with an emphasis on creating an academic program for everyone in a correctional health environment. I spent about 3 years there, and then I went to work for a community nonprofit that was D.D. Hirsch, where I was the medical director. I spent about 10 years there, and I think I ran out of good ideas. It was a vibrant organization that was a contractor of DMH, so I knew about DMH. And then around the time that I was getting a little restless, Dr. Sharon became the director of the department, and he started looking around Los Angeles to see, who can I get to come here to be a strong clinician leader, and that person was me. He called me up. We had breakfast by the beach. I think it was a fateful day because I was kind of weighing my options. I was contemplating changing jobs, and he really sold me on his vision, which was really that we're going to treat the sickest of the sick. We're going to fix a lot of things that needed fixing in the department. And believe me, there are a lot of things that we are doing better and that we can do better. He was restructuring, reorganizing, and it was really the energy behind his motivation and the team that he had put together that really compelled me to come and accept this job.
Wow, that is quite an impressive career. As a psychiatrist with the department, I thank you for everything that you do.
Well, thank you. It's a pleasure to serve.
So tell me, as your role of the chief medical officer, what is the day in and day out? What does that look like?
Well, let me just say that it's there's never a dull moment. Um, and lately, it feels like we've been going from crisis to crisis, but there is a lot of planning behind it. What we try to do is think about our ultimate value, which is to keep people in community. We really want to have people around their loved ones, their family members, to have them working, to have them contributing to society in a meaningful way. So we do have a strategic plan that we operate according to, and it's got three concentric circles. At the center is the red, which are those people that are in the most intensive situations that might be, say, hospitalized or involved in incarcerated situations with mental illness. Surrounding that is a yellow section of those people that are kind of in and out of institutions, people that are maybe not quite stable in their treatment, intensive outpatient programs, the court linkage programs. And then on the outside of those concentric circles is the green, which is what we think of as being the folks who are in the community who are maybe in outpatient care. So every day is a little different, focusing on the different programs. We have a number of staff, I think I mentioned about 6,000 altogether, both clinical and administrative, to make sure that we keep the trains going, that whatever a person needs in terms of how they enter our system, that we're able to give them access to care that is culturally congruent, that we understand that not everybody is the same. Some people are going to enter at different age groups, but we try to have one coordinated system. So I call it from cradle to grave, that we can meet their mental health needs. There's different elements of it. Some of it is preventative. We do a lot of work with schools. We do a lot of work with community-based organizations. There's a whole stakeholder process where the community actually gives input through the Mental Health Services Act, which you may or may not be familiar with. It's the funding source from a tax revenue. It's the millionaire tax, basically. They spend about 1% of their income to help support mental health services. So we have to basically touch bases with the community on a regular basis to both inform them about what we're planning to do, get their approval and I guess their input, more importantly, and then we take that to the board of supervisors. And as we implement programs, we have to make sure that we have adequate funding, the right staffing, and this all has to happen, in a course of time where we move forward and we are able to move people through our different levels of care.
Thank you for that explanation. I think that this is an interesting time, and given the economic difficulties that a lot of people are experiencing, people have found themselves really without work or insurance coverage and may not have navigated the mental health system through DMH before. Do you have any tips on how one might start that process?
Well, there has been a lot of change, but I would have to say the Affordable Care Act, when it was activated years ago, was a game changer. So that despite the economic downturn, some of the folks that may have lost jobs or may have lost revenue from jobs may have qualified still for the Affordable Care Act. So it might be that we have more people protected than we would have had California not been a participating state. But if you find yourself without a job, and most people, of course, in this country, if they work, they get some benefits through their employer, or they can go to the marketplace to purchase some plan through the Affordable Care Act. If you're uninsured or say indigent and don't have resources, then that's a part of why we're here. We consider ourselves the safety net for those people who are underinsured, who might have things like Medi-Cal, but If you call our access number, then you're able to access all the services. They'll do like a brief screening to find out, do you have private coverage? If so, they'll guide you back towards, say, an Anthem Blue Cross or a Kaiser. If you have some Medi-Cal coverage, then that might give you options of going to one of our legal entities. We have about 1,000 of those that we work with, or maybe our directly operated programs. So there's really different um, funding streams for different individuals that are seeking care, but ultimately we try to figure out what is the care that you need. That's the priority. That's the first question. We're kind of, I think of ourselves like the fire department. You don't call up and say, my house is on fire. They don't ask you, well, do you have homeowners insurance? And I think that's the same thing as a public psychiatrist. It's like when they pick up the phone and someone's in a crisis, we need to roll out. We need to send either our crisis team, or if things are more stable, we have a little bit more the luxury of time to figure out, is this an individual that lives close to one of our clinics? If not, do they live close to one of our contract partners? And also, what is their age? What is the nature of the care that they need? And we try to plug them in somewhere according to that continuum of care, despite their ability to pay.
Great. You've spoken a lot about the different resources that are available at DMH. Can you maybe, in a nutshell, kind of give the different levels of care and what somebody could, their experience might be like?
Sure. Well, let's start with sort of that center circle. DMH does not run hospitals. That's an interesting point that I learned back when I was a resident, that the county hospitals that have psychiatric inpatient units are actually run by the Department of Health Services. And we have three health agencies in this, or three health departments in this county: health services, mental health, and public health. So Health Services operates the county hospitals, but DMH has a network of contracted hospitals that take care of those folks that need acute inpatient admission. We try to avoid it when we can, but if someone's a danger to themselves or others, then they're in that level of care. It's the most acute, and it tends to be, measured on a matter of hours to days. There are also emergency services that surround that. For example, the crisis mobile response teams, some of them are paired with law enforcement, where if you call the access line, they might determine, is there some danger involved? If so, we would send out a team maybe that includes a sworn officer. Or is it something where this is a person who's at risk, but they're cooperative and they're willing to get help? We might send out what we call the psychiatric mobile response team, or the PMRT. And there are also crisis centers, urgent care centers, and crisis residential treatment programs. And that's really the most, I guess, people that are having the most difficulties, that are in sort of immediate circumstances where they need to be protected from themselves for a period of time, and get a lot of support. When people move from that environment, the step down is to go to outpatient. We think about that as being our network of clinics throughout the county, where we have different levels of care. Even with an outpatient, there is everything from the sort of wellness uh, category, where people are pretty stable. They maybe need to take a medication. They might need to see their provider or their doctor once every quarter. And then there are the folks who are at the other end of that spectrum, what we call full service partnership. And these are the folks that, were it not for intensive outpatient services, where they might have at least one contact with either a psychiatrist or a therapist or someone from that team, a peer specialist once a week, that they would be in hospital or they might be in jail. So the full service partnership is sort of wraparound services that do everything from helping with housing, transportation. They can help with benefits establishment. They can do an awful lot for someone who doesn't necessarily need to be in a hospital if we can provide them that support in the community. I would talk about another level, which is sort of the institutional level of in non-traditional institutions of mental health care. I mentioned that I spent some time working at the jail, and while there, I noticed that one striking thing is that so many of the people there are Black and brown. And there's a disproportionate, I would say, policing in those communities. There's also at times a limited access to care. So as a result, we have a huge number of folks in jail who shouldn't be there, to be quite honest. They have no business being in jail, but they're there as a function of their mental illness. what we try to do is to work with health services that provides mental health in those programs so that when they get released to the community, there is a soft landing. So we do have two unique programs that I'd like to talk about: the women's and men's reintegration programs that are part of our countywide services, so that when someone is released from being in jail or, in rare cases, prison, they can have a team that meets them, that helps them kind of almost at that FSP level, where they're going to do full comprehensive medication management, crisis intervention, and they give them the services that they need based on where they are. And this is a countywide program. The other institution that I talk about is the institution of the street. And Dr. Sharon calls it that because it's the new asylum. We have somewhere close to 60,000 unhoused individuals at any day living in LA County, out under the stars or the sun, or in this case, the smoke, as we see this month. So they're out exposed to the elements. They have untreated mental health problems. And often these are folks who are trimorbid. By that I mean they might have three different problems going on at once: a mental health problem, a physical health problem, and they might also have a substance use problem, which is pretty common. Probably about a third of those individuals experiencing homelessness at any given time have a mental health diagnosis of a severe and persistent mental illness. So we have teams that do outreach. One is called the HOME team, HOME, for Homeless Outreach and Mobile Engagement. Oh, by the way, my job is filled with acronyms. I think the first year I learned a new one every day, and I still have some that I learn about. But the HOME team is an amazing force of individuals. They go out to the streets, places like Skid Row, or in Hollywood, or in South LA, these places that are very, very densely populated in most cases. And, on a typical day, you might walk by them as you go to a restaurant or go shopping. Um, and what we try to do is have folks who get to know these individuals. A lot of them are fixtures. They might sit at the same bus stop every day and not really take in adequate nutrition. So the home teams really do outreach to that level of population. And we now have a pilot going on where we're trying to get some of those individuals conserved. And conservatorship is really when the person doesn't have the ability, because of their mental illness, to take care of themselves. They can't seek or use food, clothing, and shelter. But in the past, conservatorship would always require an extended period of inpatient hospitalization. So what we're trying to do now is pick a small number of individuals to pilot this program. And I think the first one is about to complete the process of getting into treatment as a conservatee through the Lantern Petra Short Act, which allows us to treat people involuntarily, but to do it all on an outpatient basis, where the end result might be they end up in, say, a supportive housing environment, or they might end up in a long-term care facility, but it's really getting them off the street. So that's the countywide division. I would also like to talk a little bit about prevention. I feel like I'm kind of going at full speed here, but there's so many exciting things that we're doing.
Yeah.
And from the prevention side, this is where we do a lot of work with the community. We have something called the Promotores program. That's a Latinx specific program for people who are monolingual, Spanish speaking primarily. And these are community educators. They're folks who know the community, they have roots in the community. They're not professionals in the sense of traditional mental health, like they're not psychiatrists or psychologists or social workers, but they're often people who have lived experience of the community. Some of them themselves have mental health diagnoses, but that's not a criteria. These are folks that go out and they do seminars and lectures. They might go to a local church or a community health center, or even a community park, where they do some education and outreach to educate folks for a number of different topics, everything from suicide prevention to recognizing what are the true causes of mental illness and symptoms of mental illness. We're expanding that to add another layer to it, which is called the Community Ambassador Network, or the CAN. And this network will be a little bit different. Their focus will really be on trying to provide linkages for different communities, not just those who are Spanish speaking, but to address, say, the Armenian American population, the Asian American, African American. So these are folks who will have cultural knowledge about different communities and different parts of LA and what the needs are. They'll also have expertise in knowing how to link people to resources. So that's sort of on the prevention side. Another big thing that we do with prevention is child welfare, children who are in the foster care system. And of course, this is September. Suicide prevention is a big part of that team's efforts. We do an annual conference on suicide prevention. And at this point, we're kind of blending in some information about COVID, about dealing with racial unrest, just because a big part of what we do is education.
That was a very thorough look into the Department of Mental Health, and thank you for doing that. I mean, clearly, you're very involved in the community, and I'm sure that the pandemic has affected the outreach, these services in a lot of different ways. Do you think that you might be able to talk about how the pandemic has changed things in the Department of Mental Health?
Ooh, I have a hard time thinking about how things have not changed. I mean, as you know, right now we're zooming and having this conversation. Well, I would say the first biggest change came as a result of the public health officer's order to stay at home.
Right.
And we took that quite literally, meaning that we wanted to get as many of our staff as we could out of clinics, out of office buildings, and so that they would be safe at home. We spent a lot of time, a lot of resources coming up with a virtual network that was secure. And I would say that educating our clients about what they needed to do to keep themselves safe from COVID, how to get consistency of care, even despite the fact that the clinic that you normally might go to is closed. And I would say the last convention that we put in place was a helpline that was a warm line ranging up to a crisis line. We always had access, but we knew that with all the trauma that people were experiencing from losing jobs, losing loved ones, that they might just need to have a hearing ear to listen. So we had a lot of our employees who could no longer come into the office because of vulnerabilities staff this helpline.
Wow. I mean, it's definitely clear that 2020 is a psychologically trying time. And I'm sure that the patients have very much appreciated all of these different efforts. What do you think the psychological stresses are that patients have been expressing? And do you think people are more actively reaching out mental health care?
Well, I would like to say that we're here for them when they do reach out. We don't yet have full numbers on whether there's been increased utilization across all parameters. And we've also had the unfortunate experience of a lot of our staff that haven't been able to work at the same capacity. But the biggest things that we hear are that people are concerned not so much about their higher Maslowian needs, but about creature comforts, food, clothing, shelter. There are a lot of folks who live at the margins in this town where, as you know, rent is high, it's too high, and food and clothing are not cheap. So a lot of the folks that will come into our clinics were worried about those very basics and helping them to find out if there were rent relief programs, making sure that if they didn't have benefits, helping them navigate the system to apply for, say, unemployment if they have been working. But a lot of our folks who were part of, say, uh, the essential worker category that might have worked at restaurants or worked janitorial or custodial work, they weren't necessarily laid off, but they were also having to go to work and helping them find out what they need to do to keep themselves safe. We have had a few people that have experienced grief and fear. Anxiety across the board has been quite high. Uh, I would also add that the pure number of calls that we received was increasing a little bit during COVID, but the time that it really peaked was during the month of June when there was the civil unrest that occurred. That's when our calls went up by 60%. I know it's not specifically COVID, but I do make a direct correlation between where we are with regards to the murdering of George Floyd and everybody being at home watching that, and also being fearful about COVID already. It was like we kind of poured gasoline on a fire
Yeah.
that was already there. So I think all of these things are combined, and we've at this point been trying to address them both as a department.
I'm so glad you mentioned that. I mean, let's talk about the civil unrest and the racial issues that everybody has been talking about. What has the Department of Mental Health? What can we do as physicians within the department, as a community?
Well, I would say that all of us is going to take a different path. I am a physician of color. I've been African American since birth, so I don't think that any of this is new to me and my colleagues who are also uh, from minority backgrounds or people of color or BIPOC, as we now sometimes refer to them, Black and Indigenous people of color. We know that there are disparities and that they are structural. I like to quote a person who is near and dear to my heart, who started up Homeboys. I believe it was Father Greg Boyle who talked about people not getting a first chance. So we do know that there are some structural realities where, because of neighborhoods that are under resourced, the schools aren't as good, they're not as safe. If a child grows up in this country and they don't have access to clean water, clean air, fresh food, and the resources that you need to grow and become a whole person, then they're not going to have the same advantages. I am very fortunate. I came from a family background that I have to call privileged on some level. I had both parents in the home. They both had good jobs. Nothing horrible happened to me. But I have come to realize that that is in some cases an exception, especially when it comes to communities of color. That people who grew up in traumatic environments that might have things like lead exposure, gunshots out at night, they never really had the chance to fully blossom into individuals, which is why they lean towards sometimes doing things that might get them into trouble, be it joining a gang or getting involved in drugs and alcohol from an early age, or being victims of domestic violence. That if you've been traumatized by either what happens at home, what happens in your community, or even what happens at school, if you're bullied, then you're not going to have the same ability to navigate through life successfully. So I think the biggest thing that we as providers can do is educate the public that these aren't personal failings, that an individual who struggles, be it with mental illness or with the social determinants of health being unequal, that it's not their fault. I think we come from a very individualistic culture. I would like to say that I'm a self made man and that I've got all that I've got because I worked really hard for it. But I stood on the shoulders of giants. I come from a background that education was valued. I was protected from the bad things in life. So I think often physicians, we make it this far because we've had those advantages. So to some degree, although there are those hard luck stories of people who made it through medical school and into residency without the advantages that, say, I've had, and I don't want to take anything for granted, but those individuals have to realize that, hey, not everybody had the same path that you did, and to give extra credit to folks who are struggling and to really go the extra mile to help them, be it by trying to understand things in their language, whether it be a foreign language or just the way that they communicate, which can also be through somatization. They might complain a lot about physical ailments rather than about mental health ailments. All of these things, I think we have to take into account that mental health is not monolithic in terms of diagnosis or treatment. I think educating ourselves by joining organizations that have the social justice bent. I happen to be a member of both the American Psychiatric Association and the Black Psychiatrists of America, partly for that reason, because it's an organization that really tries to give a voice to what the needs of minority communities are. But to be a woke provider, it really matters that you do some reading. And I don't want to necessarily give a book list because I don't have it right handy. But if you search around a little bit, how can you be an ally and how can you understand what someone has been experiencing as far as not coming from a privileged background?
Thank you for that perspective. I think what we can do is see each other through a kinder lens, possibly.
Right.
Yeah.
And I think that we, as healthcare providers, come to this work because we have all those high level defenses. We're altruistic. We really have the ability to sort of supplement and deny things. But ultimately, this is something that's been looking us in the face for a long time. There are so many studies that show that healthcare is not equal. If you show up at the hospital with chest pain, if you're a Black woman, you will sometimes get different assignment of medication and diagnosis than if you're a white male. Child mortality rates are very, very different. I think the most that we can do also, and I do this myself, is to mentor folks. And in my case, those folks often look just like me. I don't necessarily go hunting them down, but right now I would say I'm working with at least one undergraduate student, one post-bac student, and then a couple of medical students who are identified minorities who come to me because they say, hey, you made it through this. Can you really help us out? Helping them make connections so that they can get even if it's just helping them with their essay to focus their thoughts or to help them get into residency, medical school, all of those things. It's a pipeline. I think it's really a community effort. It's not just about pulling out your checkbook. Sometimes it's about investing the time. And I think that's something that will help level the disparities. I believe a lot of corporations now have gotten on board with trying to increase the number of professionals that are people of color.
Thank you. I think that when you were talking about students and people, it is a stressful time, and people are dealing with the stress in different ways. And we had talked about September being Suicide Awareness Prevention Month. If people are struggling, um, and some may have never even sought out mental health before for treatment or anything, what do you think you might say to somebody who is feeling overwhelmed or may even be contemplating suicide right now?
Well, first of all, I would be remiss if I did not at least mention the Department of Mental Health resources that are there on our website, which I will attempt to give you. I generally give out the phone number, but the website is probably more accessible and has more information. dmh.lacounty.gov. That's dmh.lacounty.gov. Will take you to a wealth of resources, including our 24/7 helpline, which is 800-854-7771. And there are trained staff and also some community volunteers, depending on where you get routed, that answer phone calls through our access center and make referrals to mental health screening. So if you're feeling suicidal, I guess, and you're having some imminent thoughts of hurting yourself, you probably want to call 911. If you're thinking about or contemplating suicide, there's the Department of Mental Health website with the phone number. There's also the Suicide Prevention Center run by the folks at my old employer, D.D. Hirsch. They do an enormous amount of work with prevention. But to know that there's help out there and to realize that it is generally a passing moment. And what we know in suicide awareness prevention is that most people, the vast majority of folks who are suicidal, at some point they give what are called invitations. They reach out to someone, be it a coach or a parent or a friend or a trainer. They will talk about these things, maybe in the abstract. And for us as community members to say, it sounds like you're thinking about ending your life. Can we talk about this? And to figure out if you can help them create a safety plan. If you yourself have these thoughts from time to time, maybe you're not having them right now when you're listening to this podcast, or if you did log in and you are having those thoughts, it's important to know that this is just like any other medical condition. It needs to have attention of professionals. You can't necessarily do it yourself. And to reach out to someone and to realize that with time, help is available and that might pass. So some of the other resources that we have are, there's a text line, there's the crisis line for the nation in terms of suicide prevention and crisis. So on our website, there's a whole wealth of those resources.
That's very helpful. Given everything that we've talked about a lot of things, and thank you so much for your perspective. What do you think, if there is any other message that we want to convey to the community?
Our work is yet to be done. We've only, I would say, begun some of the transformation in our society that really needs to happen. Everything from how we live our lives safely in the age of COVID, this idea that we need to protect others, which is not intuitive in a, as I called it, individualistic society. There is this expression that we have at the Department of Mental Health, which is none of us is well until all of us are well. And this means that we have to do what we need to first to protect ourselves, but a part of that is reaching out and helping others. In other words, when I think about how the community needs to change, how they view mental illness, to not discriminate against folks because they have a mental illness. They're a little bit different. I sometimes have to educate people that just because someone has schizophrenia or depression, it doesn't mean that they're not intelligent. It just means that they're struggling with something. And I think sometimes there's a misconstrued notion that the mentally ill somehow bring it upon themselves, or it's a failure of their faith, or it's some personal failing. But to realize that these things could hit anybody. We do know that 1 in 5 Americans at some point in their lifetime will struggle or have a mental health diagnosis. And to think, there, but for the grace of some higher power, that might be me, and to be empathic. I think it's really about the idea that you're going to have appreciation for what you have in life. So I think if we can all take on this attitude that we will improve our lives if we improve the lives of others, not only through the good feelings that we get from it, but the world around us will be better, it'll be improved. So I really feel that it is a community effort to do the education, to take the time that it takes to have the conversation that may be a little difficult, to go the extra mile in terms of time. And I appreciate the work that you're doing to get this good word out there from different providers, and really appreciate the opportunity to share some of this.
Thank you, Dr. Bonds. That was wonderful. Um, Before we wrap up, I was wondering if you could share a positive or meaningful experience that you may have had during this time.
Well, probably some of the funnest times that I've had, this is going to sound a little cliche, have been on the Zoom. I do a little bit of social media, but I wasn't a person who did like a lot of conferencing. But having had friends that have celebrated everything from birthdays to baby showers remotely, and it's a way that we can bring us all together. Some of the friends that I've had from college, alumni buddies, people that I know from different professional organizations, it's really been kind of a silver lining that I don't have to get on an airplane. I don't have to worry about losing my bag. I can, in a moment's notice, with the push of a button, I can be in Colorado, or I can be in California, or I can be in New York. And that has been really, really fun. And there are some folks that I had really lost contact with who I've been able to reconnect with because of these unusual circumstances. The other thing I would just say, the lack of traffic, and until recently, smog in LA has been a delight. So just this notion that we're doing things remotely, we're physically distant but emotionally closer in some ways.
Thank you so much. It really is a time of reflection and community, which is a rather interesting outcome.
Absolutely.
Thank you again for joining us today. It's been a real pleasure.
It's been a real pleasure to be here and to talk with you. And again, thank you for the work that you're doing with this series.
This concludes our final episode for season 1 of our podcast, and I'm excited to announce we will be starting a new season in a couple of weeks. A special thank you for everyone who has made this podcast a reality. Edgar Sardarian for productions, Evan Easton, Doctors Tom Shaw, Andy Lee, and Chase Coffey, all of our guest speakers, the USC Department of Psychiatry, Department of Mental Health, and specifically LAC USC Medical Center. Thank you to Michael Aguilar and Connie Castro. Over the past few months, we have covered a lot about how the pandemic has impacted us in so many different ways. For our next season, our podcast will have a new name, House Calls with Dr. K, and we will begin to take a look past the pandemic, considering issues surrounding your mental and physical health and well-being. I look forward to continue to provide you with valuable information and perspectives from leading experts in the medical field. Until next time, take care of yourself and others.